Good afternoon, everybody. Welcome to the CHPR seminar series. For some of you, this is EPI 291. Welcome to our class. For other people, it's an opportunity to get continuing medical education, CME. For others, you're just interested in really interesting research, applied research, and some of the challenges and methods. You can see in the chat, we've got the activity code if you're CMEing it. If you are EPI 291ing it, make sure you complete the 2 forms. Today, I'd like to introduce our speaker. Our speaker is Dr. Ricardo Basurto-Davila, and he's the Chief Evaluation Officer for the County of San Diego. In this role, he leads the Office of Evaluation, Performance, and Analytics, which integrates evidence-building capabilities like program evaluation and performance measurement and advanced analytics to inform policy, budget, and operational decisions for the betterment of the San Diego County region. Previously, Dr. Basurto Davila was a principal, an analyst at the Los Angeles County Chief Executive Office, where he led a data science team within the Analytics Center of Excellence. He was also a health economist at the Los Angeles County Department at Public Health, where he led the Policy Analysis Unit, a team tasked with conducting economic evaluations and health impact assessments of public programs and policies. And he was a Prevention Effectiveness Fellow at the Centers for Disease Control and Prevention, the CDC, where he led and collaborated in many studies of responses to the H1N1 influenza pandemic. He received a PhD in policy analysis from the Pardee Rand Graduate School and an MS in economics from the University of Texas at Austin. Thank you so much, Ricardo, for agreeing to speak with us today. We're really looking forward to your talk.
Thank you so much. First of all, I want to thank Jeff for the invitation to give you this presentation. He gave us his own presentation here in San Diego a couple of months ago, which we very much enjoyed, and I feel the pressure of the high bar that he left with us. So I don't know that I can make it justice, but at least I appreciate the opportunity to talk to you guys, and of course, thanks to the University of California, Davis for the opportunity to engage with you guys. You will see the short disclaimer in this slide that this is work that was actually done many, many years ago when I was a Prevention Effectiveness Fellow at the CDC. And the studies about a pandemic that many people don't even remember because we had a bigger one more recently. But I appreciate the opportunity to talk about it because I believe it's still very much relevant. And particularly because it shows us the value of looking back after something ends, diving more deeply into the data, and see what lessons we can learn to do better the next time around. And I actually think that some of the lessons that were learned from this, the main applied them in the response to the COVID pandemic. Anyway, I don't want to just keep teasing you guys. So let's, I have to give this conflict of interest disclosure. I have no financial relationship that would constitute a conflict of interest with this presentation. I should also say, like I mentioned before, I did this work when I was a Prevention Effectiveness Fellow at the CDC. My current employer is the County of San Diego, and this has nothing to do with the County of San Diego. They probably don't even know that I did this study. I know some of you are attending the session today to get training credits. So these are the learning objectives. My hope is that after the end of the session, you will be able to describe how economic evaluation can be applied to public health programs, discuss the impact of mass vaccination strategies on vaccine uptake, and interpret the results of public health economic evaluation studies. Okay, so that's it for the housekeeping. Let's get started with some background that will help you better understand the context of the study. I'm going to spend quite a bit of time on that background before we move to the details of the study, but I think it's worth doing it. So first of all, given who we have in the audience, I imagine many of you are probably well aware that children play an important role in the transmission of the influenza virus. Some of you may be kids, maybe parents of young children. And if that is the case, you're probably getting sick every other week when your kids come back from school and bring some stuff home. My wife is a school teacher, an elementary school teacher, so we went through the same. Although I think at some point you get all possible bugs and then you stop getting sick. So it hasn't happened recently, but anyway, I think it's well known. And if you don't trust my anecdotal experience, at least it's been well researched that influenza transmission rates are higher among school-age kids than other populations, and that they play a very important role in transmitting the virus. Another part of another important context is that influenza vaccine uptake is lower among school-age children, so that's kids of age 5 to 17, than among younger children. And again, parent experience may help understand this. I mean, it's easier to take your toddler or your baby to the pediatrician's office, but if you have a middle schooler or high schooler, then that becomes a little bit more challenging. Regardless of that, the main point of this is that it's been studied and estimated, like, okay, what if we seriously tried to increase uptake rates among school-age children so that they match the vaccine rates that we see among younger kids? And the conclusion is basically that would actually put a significant burden on the healthcare system, right? Suddenly, doctor offices, hospitals would have a much larger demand for vaccination at the start of the flu season every year, and it'd be a significant burden. So, if we become serious about trying to do that, then we also need to plan about how we're going to accommodate it, and whether we have any alternatives to do it in the context of the healthcare system. So anyway, that's the context for the kids. Now, tell you a little bit about the pandemic. Like I said, many of you may not even remember that there was a pandemic in 2009. I'm actually afraid to ask how old you guys were in 2009. So, but there was one, and it was an H1N1 influenza virus that started. The virus was first detected in Mexico in March of 2009. And something I didn't put in the slide, but actually just my personal experience among this. 2009 is the year that I finished my PhD. In January 2009, I was interviewing for jobs. One of those interviews was with the CDC. It was one of the 3 job offers that I received. And I accepted it in February, maybe early March, but it was definitely before the pandemic started. It also coincided that the job offer was at the influenza division within CDC. So I accepted this job offer before I knew what was coming. Right, and nobody was talking about a pandemic. They had some ideas for projects that I was going to do at the start of my fellowship. And then, of course, when I arrived to CDC in June, the WHO had just declared the pandemic an H1N1 pandemic. And again, I was working at the influenza division at the CDC. So, of course, they threw away everything they had planned for me to do during my fellowship. And they immediately told me, everything you're going to do is H1N1 related. Now, I mentioned before, many people don't even remember that this pandemic happened. But if you were there at the time, there was serious concern not at the CDC, WHO, and in general public health everywhere, because H1N1 was the same virus that caused the 1918 Spanish flu pandemic. That pandemic killed somewhere between 50 and 100 million people. It just decimated the world for at least 2 or 3 years. It was terrible, the worst pandemic, at least flu pandemic that the world has experienced. So all we knew at the start of this pandemic in 2009 was that it was the same virus. There was a lot of concern. Now, spoiler alert, it wasn't that bad, nowhere nearly that bad. You can see in the slide, the later estimates are that the H1N1 pandemic in 2009 killed fewer than 600,000, caused fewer than 600,000 excess deaths worldwide. It's not a small number, though. I mean, it's 600,000 deaths on top of what we have expected from a regular flu season, but it's not 50 million or 100 million people. But hindsight's 2020. We didn't know that at the start of the pandemic, and so once the pandemic was declared by WHO, then all kinds of measures, preparedness and response measures started to be taken by public health authorities worldwide. One last piece of context that is important to understand about that H1N1 virus in 2009 is that its epidemiology was very different from the regular flu that we see every year, what the CDC calls the seasonal flu. Seasonal flu, usually the attack rates are highest among the elderly, and the serious effects of an infection are also usually more severe among elderly adults. So the seasonal flu, we usually prioritize vaccination among people 65 years of age and older, and among a few other vulnerable groups that if they get infected with the flu virus, then they will have more serious consequences. And we don't pay that much attention to children, which we know they get infected a lot. They bring the infection home, but they usually don't experience serious consequences. H1N1 was different. The highest attack rates were among kids, and the lowest attack rates were actually among the elderly. The hypothesis is that maybe seniors had experienced similar viruses. I think there was another pandemic in the 70s or the 60s. There was a similar virus, so they may have already some immunity, whereas kids had not experienced this type of virus, and so they were all vulnerable to infection. So that's the context of the virus. Now, let's focus a little bit, let's zoom in a little bit on the timeline of what happened. In this chart, we can see roughly 3 years of data on influenza-like illness activity. ILI is, it's basically an indicator that CDC and many public health authorities use for surveillance of influenza, the influenza virus. It doesn't rely on confirmed cases, but it relies on symptoms, but it's found to be a reliable indicator of influenza activity. And so you can see here, the usual pattern that we see in the Northern Hemisphere, which is in the winter months, December, January, February, ILI activity is highest, and it goes down during the spring, the bottoms during the summer, and then comes back again in the winter. Again, the winter in the Northern Hemisphere. So we see the years of data here, and also not all flu seasons are the same, right? I mean, you can see towards the end of 2006, the 2006-2007 flu season, the peak was relatively low, and 2007, 2008, there was a higher peak, and then the 2008, 2009 season, it seemed to be, relatively mild, at least compared to the previous one. You can see at the start of the year in 2009, the peak was much lower than the previous year, but then we see I should have already clicked. Sorry, I'm talking about 2009. But then we see the spring, suddenly it comes back, right? And that's when public health authorities, not me, because I was still finishing my PhD and I was naive and I was not paying attention to anything that was happening anywhere else. But then, the virus was detected in Mexico. We started seeing here in the US outbreaks of the virus. And so we see March, April, May, there were outbreaks here and there during the spring, and then that died down during the summer. So we see it died down during the summer. The US got a break. The Northern Hemisphere countries in general got a break from the virus, but it continued in the Southern Hemisphere. So countries like Argentina, Australia, countries in the Southern Hemisphere continued to see the virus activity. And we knew in the US that it was going to come back up. I guess the smarter people, epidemiologists, they know how this works, and they knew, okay, this continued to, to spread in the Southern Hemisphere. The summer gave us a break, but it's going to come back in September, October. So that's what we knew. And as you can see now, the peak was much higher, right? It was a very high peak in terms of number of infections, or ILI, I guess, at least ILI activity compared to the previous season, which had already been a very strong season. So that's roughly idea of the timeline. The other important thing for you to know is that the vaccine didn't become available until, you're seeing here, the first week when the vaccine was available in the US. It was already after the activity had come back. The second wave of the virus had already started. It had been around for a few weeks when the vaccine first became available. Now, it was still not at the very, very peak. So there was still value in getting people vaccinated, but it became clear it was very important to get everyone vaccinated. And, they knew months in advance that the vaccine was not going to be around for a while, until the end of October. So at least the US had time to prepare for it. The other countries were not, in the Southern Hemisphere, were not as lucky that, they were dealing with the outbreaks and there was no vaccine. So they were just implementing all kinds of other response activities, waiting for the vaccine to become available. So that's the timeline of the two waves. The first wave, which was relatively mild, and then the second wave, which was much stronger. Now, what happened in between the two waves? Well, what I mentioned is, the virus continued in the Southern Hemisphere. So the US essentially said, okay, let's learn as much as we can from what's happening elsewhere. I started my job at the CDC in June of 2009, and like I mentioned before, the virus, the virus was first detected in Mexico. So the U.S. sent everybody who spoke Spanish to Mexico. Everyone who spoke Spanish was in Mexico trying to figure out, tracing the origins of the virus, analyzing the virus, looking at, understanding what was going on there. And then we saw, well, this is continuing in the Southern Hemisphere, and we should learn about what's happening there to anticipate what's going to happen here. So Argentina in particular asked the CDC and the WHO for help. They said, well, we're doing all kinds of different things here. They closed all their schools for a whole month, everywhere in the country. They implemented a bunch of, different responses at household level and all kinds of different things that Argentina was trying to do. And they wanted CDC to help them learn what was working and what wasn't working. And of course, CDC said, yeah, of course, because then that also helps us figure out what we're going to do when this thing comes back in October. The problem is that everybody who spoke Spanish was already in Mexico. So I didn't know anything about the flu, but I spoke Spanish. So they sent me to Argentina, and I spoke a month in Argentina, and there were two others at CDC who also were Spanish speakers that were not necessarily experts in influenza, but they figured, okay, let's see, please go work with the Argentinian government and learn as much as you can and bring back some lessons for what we can do. So that actually has nothing to do with the study we did in Maine, but it's just the context. So it was interesting to say the least. So anyway, in addition to trying to learn as much as we could about the virus, what was happening elsewhere, then obviously the US was working really hard in developing the vaccine. The US led, just like with COVID, the US led the development of a vaccine for the H1N1 virus. They had already started developing a vaccine for the seasonal flu that was circulating at the start of the year, but the H1N1 was completely different. So it started late, which is why the vaccine arrived so late in, basically not until the start of October, whereas the seasonal flu was available a couple of months before. And then, of course, they were preparing the logistics for the mass distribution of the vaccine because we knew that it was going to come as it did, that it arrived at the start of October. We knew that it was going to be close when the vaccine was going to be available, and we had to vaccinate as many people as possible because otherwise we're going to miss, what if we start vaccinating in November, then the peak had already happened and then there would be no point. So that was the pressure. And many of these logistic decisions, and I'm not an expert on this, but so take my word with a grain of salt. But my understanding is that, the federal government essentially was responsible for distributing the vaccine to state governments, and then state governments decided how it was going to be distributed internally. So there was a lot of discretion for states to decide what we want to do. And that's important because, Maine had already decided um, before the before the pandemic started, they had already planned to pilot a school-based influenza vaccine program for the seasonal flu. So just whenever the regular season, the flu season started, they had planned to, let's see if we can do mass vaccination in schools, precisely thinking about increasing vaccination rates among school-age children. What I said at the beginning, that school-age children usually have lower rates of vaccination. Maine CDC figure, let's see if we can increase those rates by doing vaccination in schools. It's a pilot. See if it works, and if it works, we keep doing it. They had already planned to do that, and then the pandemic arrived. They realized we have to vaccinate a lot of people right at the start in October, and this virus affects children more than adults and the elderly. So, hey, this pilot that we have been planning sounds like it's the right thing to do for this pandemic. So they decided to go all in vaccinating, the school influenza vaccination program. And by all in, I really mean all in. Like among the things that they did is all the early supplies of the vaccine were distributed directly to schools. So, whereas other states, many states did some version of mass vaccination, right? But in some cases, if you were around, well, obviously you were around during COVID, so you may have gone to a mass vaccination at a park or a library. So many states did something like that. But Maine focused all the early efforts in schools, and it was vaccinating children in school settings. So, and all the early supplies of the vaccine, or most early supplies of the vaccine, were prioritized to school settings, which of course implied that the regular settings of vaccination where adults and the elderly regularly got vaccinated, they were deprioritized. And so those vaccine shipments to hospitals, to doctors' offices, they came later, which also may have affected, when and how many adults and elderly were vaccinated. By some estimates that CDC did later on, doing a survey of schools, it's a sample, so it's an estimate. It's not for sure, but they estimate that 98% of schools in the state participated in the school vaccination program. So it really was a statewide effort led by Maine CDC, the Maine Centers for Disease Control, and Maine, the Department of Education in the state. Okay, so that's the context. And I know I'm supposed to be talking about a study, and you may be wondering when I'm going to get to it. So now, now I'm going to get to it. I hope that helped paint at least a somewhat clear picture of what was happening, the context for the pandemic, and then the decisions that state had to make and why Maine decided to do what they did. Um, so um, the study that we did, and like I said, Maine went all in the school vaccination program. They were convinced that it was the right thing to do. They were convinced that it was a success, but they wanted confirmation, right? They didn't want to pat themselves in the back and just say like, okay, we did great. This is awesome. They asked CDC, can you come? We're doing this. We think it was the right thing to do. Can you come and bring your expertise and help us see if indeed it achieved what we think it achieved. And so CDC sent a team of folks to Maine, including me. I spent a few weeks in Maine working with Maine CDC, with a few school districts, collecting data, etc. This is one of many studies that we did in Maine. Presenting this one because this one was my study. I led all the work that I'm presenting here. And this study had basically two main research questions. One of them in general was, what was the impact of the Maine school vaccination program on vaccine uptake? That was the generic question. Then, there are some sub questions that we had. First of all, obviously, did it increase vaccination? But second, it was important, did it also lead to faster vaccination? Because that was very important in this particular year. And then, given the fact that it was focused on children and that it deprioritized vaccination in other settings, then they wanted to better understand how the impact varied across age groups. So that was the first part. And it was, I would say that was the main interest in Maine asking CDC for help, is that's what they really wanted to know. But CDC was also, CDC has been prioritizing for a couple of decades now to include an economic perspective in public health work. And so CDC said, absolutely, but let's also do an economic study, right? In addition to the impact, the epidemiology take of the impact of the program, let's look at the economic impact of the program. And I'll say, I'm going to take a pause here to say a little bit about health economics and public health. So health economics is, I would say, it's a mature field in the healthcare sector. For a while now, there's been a lot of work, and it's used and has a lot of value in understanding the economic impacts of decisions regarding medical care. And not so much in the US, but in many other countries, economic analysis is actually used to make those decisions. Like, for example, in England, the National Health Service, they make decisions about reimbursements to healthcare providers based on the estimated value of medicines or treatments. And so, this medicine has X impact on disease, on healing people or helping ease their symptoms, etc. So they put a value to that impact, and they say, okay, then this is what it's worth, and this is how much we're going to pay you for the medicine based on the value of your medication or the value of your treatment, the value of your devices. This happens less in the US for various political reasons, but still, in general, the field is well developed in the healthcare system. It is a lot less developed in public health. And I would say CDC is among the leaders worldwide. I'm not sure if it still is, given what's happening this year in the federal government, but CDC has certainly been among the leaders worldwide in pushing health economics increasingly in public health. And so CDC has a number of health economists. It was the program that I was doing at CDC. My fellowship was to train in health economics, and it was to bring the economic perspective to this analysis. And it's still, I know, and for some of you and many certainly that I've worked with, it's still a little bit strange to think about public health and dollars in the same sentence. And I know it makes some people uncomfortable. But I hope at the end of the session, I'll have made a case for why it can be useful, it can be valuable. It helps us think about the impact of something in different terms, that highlights the potential differences in the value of what's happening and can sometimes help reconcile, well, this caused something good, but it also caused something bad. Then how do we compare? It's like, how do you compare an influenza infection among a child to an influenza infection among an adult? Uh, an epidemiologist won't be able to tell you that, right? But if you add an economic lens to it, it may help you better understand, okay, maybe that's a good way to think about it. So anyway, that is a context just to say that we also wanted to understand the economic impact of the program. First, on healthcare costs, right? I mean, first of all, there are costs due to vaccination. If you go to a pediatrician's office and you vaccinate a kid, then there's the cost of the vaccine itself. There's probably some time for a nurse. A nurse may spend 5 minutes with you, and then the physician may spend another 5-10 minutes with the kid, and some administrative costs. So that happens at a pediatrician's office. The cost structure was very different at the school vaccination. It's a mass setting, so there's a nurse, there's still a vaccine, but the costs are very different. There can also be difference in cost, healthcare costs, due to the impact of, if you get more people vaccinated, then there should be fewer infections, and then that's going to result in fewer healthcare costs, right? And also productivity losses. If I don't get infected, then I don't miss time from work. If my kid doesn't get infected, then my kid didn't have to stay home, and then I didn't have to stay home with my kid, and so I didn't miss work either. So all of these different potential impacts, direct and secondary impacts, we had to take into account. And also, even small things like if I take my kid to get vaccinated in a pediatrician's hospital, then I have to drive there, and so that's also a cost to the hassle of the cost of driving and the cost of the time. So those are the various types of costs that we accounted for in this. If you want to learn more, then of course there's a paper with a technical appendix that provides a lot of detail. Jeff did ask me not to spend a lot of time on the nerdy stuff. So I'm not going to spend a lot of time on this slide, but I figured I should at least give you a sense of what we did. And so for the first research question, to estimate the impact of the program on vaccination rates, we applied a statistical method called difference in differences. It sounds fancier than it is. It's actually not really that complicated. It just has a fancy and kind of annoying name. That helps us address different types of biases that can be, that if you're not careful when you're trying to do a study like this, particularly when you're trying to assess the causal impact of something on something else, then if you're not careful, you can suffer from different biases that will make your results invalid. And so among the things that we had to worry about when doing this study, we're trying to understand, well, did this program increase vaccination rates? It's a simple question, right? And some people might say, well, just look at vaccination the year before against that year, or look at vaccination in that year, Maine compared to the rest of the country. So there are different ways that you can do the analysis, but there are also many potential biases associated with them. For example, maybe Maine before 2009 was already better at vaccinating than other states in the country. Maybe they've always been better for whatever reason. Either the healthcare, public health authorities are really good, or maybe the culture in Maine leads people to be more likely to be vaccinated, but maybe they were already vaccinated. So just comparing what happened at the end of the year, Maine versus the rest of the country, that could be subject to that bias. Or maybe everyone got their act together in 2009, and we all did much better in vaccinating against H1N1 than we did in previous flu seasons. So just comparing Maine vaccination in 2009 versus Maine vaccination in 2008 may not be valid because maybe everybody was doing better, right? And finally, Maine's program focused so much on the early vaccine shipments, giving them to schools, and then the rest of the flu season, it was roughly the first 9 weeks of the flu season when the vaccine program was very, very strongly emphasized. And so that was also important. It's like, if we don't account for that timing of the implementation of the school vaccine program, then we may also be missing some of the important details on the impact of the program. So these are the biases that we wanted to account for. And then obviously it's, doing this analysis for different age groups, because again, this was so focused on school age children, and we want to better understand how it affected adults, the elderly, and then younger kids that are not in school, 6 months to 4 years of age, who were not the focus of the program. So on the right side, you can see a regression model. That's just the regression model that we use for that, for the differences analysis. Again, it looks more complicated than it really is. Once you go through this in your head, and you have the data, then doing the actual analysis is not that difficult. So that was our statistical analysis. to answer the question of what was the impact of the program on vaccination. But then we also had the second research question on what was the impact of the program, the economic impact of the program. And that's more complicated to answer because then you need to take into account not only vaccination rates, but then how vaccination rates affect infection rates. And then vaccination can happen before you get infected, which then it means that you may, the vaccine may give you immunity and then you won't get infected, or the vaccine may not give you immunity because it's not 100% effective, and then you can still be infected after vaccination. And then if you do get infected with flu, it can be a mild flu or it can be a more serious flu. So you may not need to go to the hospital and just stay home, or you may need to be hospitalized and stay in the hospital for a couple of days or for a few weeks if it's a more severe infection. And all of that has different costs, both in the healthcare system, but also for households and also for productivity losses, right? So we had to take all of this into account. And then because we wanted to take into account the timing of vaccination, so we couldn't do just like a one-time analysis to see what happens at the end, but we had to look into, okay, week by week, as we see the data that we had on vaccination rates over time, then how does that affect, you know, vaccine uptake, infection rate, hospitalizations, deaths, costs, all of these things. So we develop a simulation model, and what you see on the screen is actually a very simplified version of that model to try to capture all of this. This basically what you see on the screen is 1 week in the model where we started in week 1 of the flu season saying, okay, everybody at the start is susceptible to get infected with the H1N1 virus. We don't know if it's a fully reasonable assumption because, you know, like I said, maybe some elderly people who had some immunity to the virus, but we don't have good data on that. So we just assume everybody at the start is susceptible to infection. And then we go through all of this flowchart in 1 week, whether do you get vaccinated? Yes, no. If you get vaccinated, are you immune? Yes, no. And if you're not immune, are you exposed? And if you're exposed, do you get infected? Yes, no. And then on the other side, if you don't get vaccinated, then do you get exposed and you get infected? And again, this is a simplified version because a lot of stuff can happen during this in each of these nodes. So for example, if we center on this influenza infection node, you know, if you get infected, then it can be a mild infection, it can be a serious infection, and then that has different kinds of costs on the healthcare system. It has different costs on the household side. And then if you get infected, you can still get vaccinated, right? Because some people don't, if you didn't have symptoms, you may not even know that you got infected, or you may still decide to get vaccinated just because you don't know that you may already be immune due to infection. So you may get vaccinated, but then that vaccination has pretty much no practical value because, you know, you were already immune due to infection. So again, the model does this for 34 weeks. It runs through all of this. Obviously, if you're already immune, then some of these nodes don't apply. But it simulates what happens over time, the decisions that individuals and households make about vaccination, and then what could happen using the data that we had available at the time to capture the costs. And it was doing this for 2 different scenarios. One scenario was school immunization program, the data that we had on what happened in terms of when people get vaccinated at what different age groups, what percentage of them get vaccinated in each week, and then a counterfactual scenario, which is just a fancy word to say what would have happened without the immunization program, the school-based program. So it ran all of this for 34 weeks under those 2 scenarios. With the school vaccination program and without the school vaccination program, it captured the costs across, over time, and then it spit out estimates of, okay, this is what will happen in terms of economic costs. So that was our simulation model to do the economic analysis. Okay, before I show you the results, I want to show you just some data, some of the data that we had available at the time. This is what happened during the 2008 influenza season and the 2009 influenza season. The darker lines is Maine. These are vaccination rates in Maine. And then the lighter color lines are a sample of 15 states for which we had data. On the left side is 2008, on the right side is 2009. So 2009 is H1N1, and 2008 is the regular flu season from the previous year. And the short version of this, as you can see in the slide, in 2008, Maine and the rest of the country were very similar, right? I mean, you can see here for 6 months to 4 years of age, for 5 years to 12 years of age. The lines, the solid lines are very, very close to each other. There was nothing particularly great about Maine in the 2008 flu season, except maybe among the 50 to 64-year-old age group and the 65 and older age group, where we do see that Maine was doing better among those age groups, but certainly not among school-age children, right? If we move to the right side of the charts, then we see that the story completely changes. Maine did much better than the other 15 states, especially among kids. Uh, School age kids, 5 to 12, 13 to 17, and interestingly, also among 6 months to 4 years of age. That is an interesting one that I don't know that I have a good answer for it. They were not the focus of the school vaccination program. We didn't really do a study of that. It was surprised when we looked at the data at the end. I'm going to guess that there may have been some behavioral response from parents of kids who got vaccinated in school. They became more aware that vaccination among kids was important, and they may have been, more willing to bring also their toddlers and babies to get vaccinated somewhere else, not in schools, because that they were not being vaccinated in schools. The other part that I want to highlight is we see, especially among the 18 to 49 group, that in the first 9 weeks of vaccination, the main line is slightly below the other state's line. So the switch flip here, that in those weeks, fewer adults were vaccinated in Maine, or a lower proportion of adults were vaccinated in Maine compared to other states. And again, I'll explain by the fact that Maine was prioritizing school vaccination as opposed to vaccination among other age groups. So if you think about all the different comparisons you can make based on this chart, that's essentially what our differences analysis did. It's just the value of doing the statistical analysis is that everything you're seeing here that you're trying to process, comparing left to right, comparing one age group to another age group, and comparing Maine versus the US states, darker lines to light lines, shaded lines to the other lines, all of that is captured in the difference analysis, and it puts everything into numbers, which is what we can see in this table. So this table shows the results of our statistical analysis. Like I said, we ran 6 regressions, one for each age group. And the second column shows you the estimated impact of the school vaccination program among vaccination rates for each age group. So you look at the top row here, we see that the estimated impact of the program is increasing vaccination by 22% among young kids, and then among 25 and 21% among school age children. So these are large and statistically significant. You can see at the last column, p-value less than 0.001 just means it's very statistically significant. Large impact in increasing vaccination rates among children. Then you see, not surprisingly, because of everything I've been telling you, a negative impact among adults 18 to 49 and among adults 65 and older. But the impact is not as large, right? It's 6%, roughly 6% in both groups. So in that sense, we can say, well, we're trading off, high vaccination rates, much higher vaccination rates among children for slightly lower vaccination rates among adults. But then the third column shows you what this means in terms of number of doses. And as you can see, this 5% then suddenly doesn't look so small, right? We estimate that the program decreased the number of vaccinations among adults by 30,000 compared to an increase of 29,000 among 5 to 12-year-olds. So those 5% numbers, 6% numbers don't look so small anymore. Now, I didn't put a total row in here. I should have, but if you do the math, we estimate roughly that the program still resulted in about 24,000 more vaccinations across the state, across all age groups due to the program. So on the net, we say, okay, the program did increase vaccination. Even if it decreased it among some age groups, it still increased vaccination. Okay, that's the story that Maine wanted us to, the story that Maine was interested in, right? How did the program affect vaccination? But then, like I said, how do we weigh, lower vaccination rates among 18 to 49-year-olds to higher vaccination rate among children? Right? One is not good, no matter what you think. I mean, it's not good that we vaccinated fewer adults. The other one's good. And yeah, there are more doses, but is an infection among a child the same as an infection among an adult? Maybe. And what about elderly? That we've seen that in regular flu seasons, the elderly are very vulnerable to infections. They can have severe consequences among them, and they also decrease infections, vaccination among them. So this is where economic analysis can help us bring a little more light into it. And so these are the findings of our economic analysis. I apologize in advance because economists don't make things easy. I was thinking earlier today how to walk you through these numbers, and it's almost a tongue twister sometimes. But anyway, the second column in this table shows what we call the incremental cost, and it's basically just the change in costs due to the specifics of the vaccine program. And I should warn you, and Jeff may not like this because it's not best practices in health economics, but in this case, we mingle not only the cost of the program itself, but also all the costs associated with vaccination. So anything that was a cost associated with vaccination was put in here. And so, there's a cost of implementing the school-based program, bringing tables so that you can put the supplies in there, and then having the nurses be at the school, and transporting the vaccines to the school, etc. There are costs associated to the implementation of the vaccine program, but also if the vaccine program increases or decreases vaccination, then we included that in the incremental cost calculation. So anything related to vaccination, the costs that were related to vaccination are in the incremental cost column. So what we see here is, for example, the program generated incremental cost of $500,000 for children of age six months to 4 years. And then it had negative incremental costs for children 5 to 12 years of age. Now, this is going to get confusing a little bit. Negative costs are good. So if we see a negative sign in this column, that's a good thing because it's lower costs. Why did it increase costs among 6 months to 4 years of age? Well, very likely it's because more of them get vaccinated, but they were vaccinated at pediatricians' offices. So, that increased the cost for them because vaccination at pediatricians' offices is expensive. For the other children, the program increased vaccination, but it was in school settings. And school vaccination is cheaper. It's like the Costco of vaccines, right? You buy a lot and it's cheaper by the unit. And so I just thought about that Costco example like 40 minutes ago, by the way. But anyway, so there are negative incremental costs for kids because they were vaccinated as the schools, and the schools are cheaper. And so that's a good thing. We have lower costs among children because vaccination was cheaper for them. Then we have negative costs among 18 to 49 years old. And we can say, oh, that's a good thing too. But it is important to understand why. It's because fewer of them got vaccinated. So we showed you there were 30,000 fewer adults of that age group who were vaccinated, and that's why their costs are negative. Their incremental costs are negative. So a dollar is not necessarily a dollar in this case because it's for different reasons. And some reasons are good, cheaper vaccination. Other reasons are not good. It's less vaccination, right? And it's the same thing for 65 and older, that the negative incremental cost of almost $800,000 is because fewer of them got vaccinated. Okay, that's the incremental cost column. Then we move to incremental benefit. And now in incremental benefit, this is essentially productivity, avoiding productivity losses. So if I didn't get sick, then I was able to go to work today. If my child didn't get sick, then I can also go to work because I don't have to stay with my child at home, right? So incremental benefit in this case is basically just the estimate of those productivity losses. And so we can see here, in this case, incremental benefit, negative is bad. So again, bear with me, sorry. Negative is bad in this column, negative was good in the other column. So we see positive incremental benefits across the board for children, because again, if children did get infected, then their parents didn't have to avoid going to work. And the cost of vaccination didn't play a role here. So all of them got positive incremental benefit. Among adults 18 to 49 years of age, the incremental benefit was negative, small, but negative. And then why? Well, because fewer of them get vaccinated, right? Fewer of them got vaccinated, which means more of them probably got infected. And then they had some productivity losses. But the infection rates were so small among adults, and the serious effects of infection were also so mild that the incremental benefit the negative incremental benefit was not very large. And we see similarly a very small negative incremental benefit for among the elderly. So good here, the first 3 rows, bad in the 4th and 5th row, but the bad is not that bad. If you're confused, then just look at the 4th column, net benefit, which is where the 2 of them are put together. And it's a subtraction. So again, messy, like negative 235,000 minus negative 2 million, it actually results in positive 1.8 million. So, but the bottom line is that in this last column, positive is good. So, we see positive incremental net benefit across the board, except for 50 to 65-year-old, and that was really small. And that's also the only age group for which we don't really see statistical significant impact. So we can pretty much ignore that, this one, the 150,000. And so overall, across the state, once you add up all age groups, we see a net benefit of $5 million for the program. And so, essentially, the question I asked in the previous slide is, well, we see good here, we see bad here. Overall, is it good? At least if you use economic analysis, you get an answer that yes, it was good. If you don't like to see this all in dollars, there are other ways to do this. If you've heard of QALYs and DALYs, that's also tools that health economists use. We could have done this analysis with QALYs and DALYs, which are measures of health, but that summarize, health and well-being and in a single number that can also be used to summarize everything to get a more definitive answer that it was good or not good. We use economic analysis, we use dollars, and we get a final result that yes, we can say that the school vaccination program led in a positive benefit at the end of the day. The last column is just, I think I forgot to say that we ran 10,000 simulations. And so we estimate in what proportion of those 10,000 simulations we have a net benefit that is positive. And as you can see, at the end of the day, overall, it's 98% of the 10,000 simulations had a positive net benefit. So, it's fairly conclusive that we can be confident in saying that the main school vaccination program had a positive economic benefit, but with some caveats. And that takes me to the final slide. Well, not final, but, in terms of the implications of our results. And, there are basically four implications. The first one is we find that the school vaccination program in Maine significantly increased vaccine coverage among children. That was the goal of the program. If you look at just that, it was a success because that's what they wanted. They wanted to vaccinate more children and they wanted to do it quickly. It achieved both. But the increase in coverage among children came at the expense of lower coverage among adults and the elderly. That's something they didn't intend to do, although I think they realized that it could happen and they decided they could live with it. But, it's very clear that that's actually what happened. Now, in this case, because of the epidemiology of the virus, that the effect, it was more important to vaccinate children than the elderly, it actually worked out okay. And there was a net positive economic benefit of $5 million statewide. And so, again, it led to fewer adults being vaccinated, but the negative impact of those fewer adults being vaccinated was not that bad compared to the positive impact of increasing vaccination among children. So finally, to me, the most important finding is just if it had been different, if H1N1 had more the traditional epidemiology of the flu virus, we, instead of a success story, we could be using this as a cautionary tale, right? We might have had more serious infections, a lot more deaths among adults and the elderly, and we will be speaking very differently about this. And so, and I'll say this, Maine really appreciated seeing this broken down this way because they realized, yeah, next time around, we only want to do something to make sure that we don't reduce vaccination among other populations that, that may be affected and that the story may not end up being the way it turned out in 2009. So to me, that last one is the important part of that. When designing a program, you need to think very carefully about the potential consequences and see how you can minimize the negative impacts of those potential consequences. So that's it. I just want to acknowledge a lot of people were involved in this. I'm the talking head today, but sorry. Sorry, I heard something. Anyway, just to wrap up this slide, CDC, the influenza division, they mentored me. They taught me so much in the 2 years that I was there. Many researchers from the National Center for Emerging and Zoonotic Infectious Diseases also worked on this, and I feel for what's been happening to both of them in the last few months. The Maine Center for Disease Control was crucial for all this work. They were the ones who asked us to come over. And then the Maine Department of Education, that they gave us access to a lot of data and a very good understanding of what they did, what they were trying to do. If you want to learn more, everything I presented today is published in the Health Services Research Journal. You can, I'm sure we'll share the slides with you guys so you can find the publication if you're interested. And then a few years ago, Dora Mills, who was the director of the Maine CDC, she published an article in Health Affairs where she made reference to actually our study and how it in fact impacted decisions that they made during the COVID pandemic. Dora is no longer at Maine CDC. I think she's now at the University of Maine. But interestingly, her sister is actually the current governor of Maine. And I think she's thinking of running for the Senate. So anyway, that's a side note for politics that Jeff probably didn't want me to say that, especially because we're recording. um, anyway, that's it. Yes, we only have 10 minutes. Sorry, we
10
ran longer
minutes,
than
that's
I
perfect.
expected.
Ricardo, that's perfection. That is wonderful. Thank you for giving such an approachable talk and for giving us the context and the background. There's opportunity now for people to ask questions. You can ask for more Greek letters or less Greek letters. You can ask for maybe some lessons researchers might want to learn from experiences working with practical people. Does anyone have any questions? You can type them into the chat. You can use the virtual hand. Thank you. Jijuan, are you okay to go off mute and ask your question?
Yeah, sure. Can you all hear me?
We can. Thank you so much for your question.
Yeah, thank you. I mean, that is a fascinating talk. Yeah, really enjoyed it. So toward the end, I have this question. So the uptake, uptake of a vaccination rate in kids seems to come at a price with like a lower vaccination rate of adults, especially like 19 to 18 to 49 years old. Yeah. So I am thinking, so I have two questions. So the first one is that uh, is there sort of like a causal relationship, like maybe more adults need to take care of kids, like vaccinations, that does that like sort of cause the decrease of adults vaccination? And then so that's like first question. The second question I have is that so yes, if with another sort of infection rate, like the net economics might not play the same, like might not be the same as the current one. But if we have like a different infection rate profile, will that also kind of change people's behavior? Like, you know, maybe if like more adults will get infected, they will actually have more vaccinations. So it's just like something I'm kind of debating in my mind, I
Yeah.
guess.
Both are great questions. The first one is easier than the second one. Um, yeah, if I understood the first question correctly, is you're asking why did fewer adults get vaccinated? And uh, the short version is basically they didn't have a choice because
Mm.
at the start, when the vaccine arrived in October, Maine CDC just sent most vaccine supplies to schools, and
Oh.
adults couldn't get vaccinated in schools. So very few supplies were sent to doctors' offices and hospitals. And I don't remember details; it was a while ago, but I think there were also some, priority groups,
Mm.
elderly people with immunocompromised illnesses. Who were immunocompromised, they probably had priority to get vaccinated in other settings. And so most adults basically just had to wait. Some, just saw the vaccination was not zero among them, but it was certainly much lower. And essentially, it's because most vaccines were in schools and they were given to children. So I think that answers your first question. The
Yes.
second one, it's a great question, and the short answer is I don't know. I mean, you're right that some of what we saw here uh, may also be those behavioral decisions, right? I mean, so adults, they even if they maybe they didn't not only they couldn't get vaccinated if they want to, but maybe some of them didn't want to because they had already heard that the infection rates were not that bad among adults and the elderly. That's a little tricky to discern. I mean, I think our statistical analysis does control for that by comparing to previous years and etc. But the part about if the epidemiology had been different and infections had been more severe among adults or the elderly, if that would have resulted in behavioral responses, most likely yes. And um, you know, the economists will, let's say, ceteris paribus, which is everything similar. So if we say a different epidemiology with a different behavioral response, but the same program prioritized in schools, then I'm guessing it would have been chaos, right? I mean, it's adults trying to get vaccinated and then they can't because the schools are vaccinating only children. And if you know that, if if you're an adult and you get infected, it can have very serious consequences. And I don't know, there have been protests. I don't know. But in this particular case, because folks knew that children were at higher risk, and Maine CDC, I'm sure I was not there at the time of the vaccination program. I was there afterwards, but I imagine they probably did a good job in communicating why schools were being prioritized. So it seems to have gone smoothly. But yeah, like I said at the end, things could have been very, very different with different epidemiological circumstances, different if the virus had been different. I hope that
Thank you
answers the
so much.
question.
Yeah, you did. Thank you so much. And
Thank
I kind of overlooked the part of availability, and that's really helpful with the
Mhm.
priority list. Thank you.
And thank
Sure.
you for your question. Ricardo, we have time for one more quick question. Hillary, are you okay to go off mute and share your question for a quick answer from Ricardo?
Sure. Thanks, Ricardo. This was fascinating, super interesting. I was curious if you, when you were doing this analysis, if you were aware of any other states that had either similar vaccination programs at schools, and if so, did they evaluate them and did they find similar results? Kind of about, especially around that, like if the epidemiology had been different,
Yeah.
the results could have been different.
I'm not aware of any other evaluations of school vaccination programs, at least not during that pandemic.
Yeah.
I know at least a couple other states, I think Hawaii was one of them, I don't remember the other, did some school vaccination, nowhere nearly as comprehensive as Maine. Like I said, Maine really was the only one that went all in. And again, what made Maine special was that they prioritized all early vaccine shipments, they sent them to schools, deprioritizing everything else. Other states, they did, they try to vaccinate children in schools, but they didn't necessarily reduce vaccine supplies in hospitals or doctors' offices. So Maine was the one that definitely went all in. Again, Hawaii and another state, and I'll be honest, this was a while ago. I think we excluded the 1 or 2 states that we knew had done some school vaccination from our analysis, but I'm not 100% sure. But I know that it's, if you look for the paper in the technical appendix, says whether we did or didn't. So that would be
Thanks.
there. Mhm.
Thank you for that question. Kate, we've got 1 minute left. Can you ask your question quickly? And Ricardo, can you answer Kate's question quickly?
Sure.
Kate, are you okay to ask your question?
Yes. Hello. Thank you so much. I'm really curious about your career since then. I know you can't do that in 1 minute, but it seems like you were able to do really in-depth research while you were a CDC fellow. And what is your position now? And do you do that type of research, or do you rely on that type of research from others?
Jeff is gonna roll his eyes because I think he's heard me say this like 3, 4 times already. But yeah, so thank you. Summarizing my career in 1 minute is tricky, but I spent 2 years at CDC doing this fellowship. I actually had an offer to stay after the end of my fellowship at CDC to continue at the influenza division doing economic analysis of influenza public health efforts. At that time, I got an offer to come to the Los Angeles County Department of Public Health, and essentially it was at CDC I was going to be the flu economist. In LA County, I was going to be the public health economist. So it was an offer to lead any health economic analysis in public health in LA County. So I'm more of a generalist. I really love the idea. I went to LA County. I continued working in public health. I did some economic analysis, not as much as I wanted to, because it turns out that the interest was broader than that. And then I spent a few years in public health in LA County. And then the last 10 years of my career or so, 9 years of my career, I even moved into more generalist area of not just public health, but government in general. So in LA County, the last 4 years of my career in LA County were at the county's chief executive office, where I did a lot of program evaluation, not necessarily public health. It could include homelessness, justice system, different types of program. And that has continued here in San Diego County, where the difference now is in San Diego, I lead a whole department of 18 people where we do research and evaluation in many different areas. And we do a lot of other, maybe slightly more boring stuff like performance metrics, data analysis, generic types of data analysis. I wouldn't say boring, but it's different from evaluation. But anyway, that's been my career path so far, because I'm a generalist. Somebody else might have said, like, I definitely want to be a flu economist and stay at CDC. And I'm sure that would have been very satisfying too.
Thank you. A wonderful question, Kate. Thank you for answering quickly, Ricardo. We really appreciate you sharing your experiences and your research with us today. We'll be posting the recording so people can watch it. Ricardo, if people want to connect with you, what is the best way for them to follow up?
Send me an email. I'll be happy to. If I don't know, when you send the slides, you can include my email if it's not in the invite. But very absolutely, I'll say this. I enjoy, I enjoy helping folks. Many of you are early in your careers and maybe you're trying to decide, do you want to stay clinical? Do you want to go to the research side? Do you want to go to academia, the government, the industry? So I don't have experience in all those areas, but to the extent that I can offer advice, or if you want to learn more just about this specific research, then happy to answer any questions any of you may have.
Super. Thank you so much for your time today. We really enjoyed seeing you and hearing your talk.
Okay, well, thanks everyone. Have a great rest of the week.
Thanks. Bye for now.